صباح الخير. Sorry for the delay. There is some speakers are missing, and we will start with Professor Hanan Shafi, a professor of medical oncology in NCI. She will talk to us about immunology in early stage non-small cell lung cancer.
اوكي صباح الخير. اولا انا بشكر استاذ دكتوره ريم عماد على دعوتها الكريمه ليا ان انا اكون ما بين اللانج جروب النهارده. ان شاء الله النهارده هنتكلم على الاميون ثيرابي in early stage breast cancer. الحقيقه انه by the time being there is an indication for immune therapy in every stage in lung cancer. What I'm going to discuss today is the role of immune therapy in the early stages. So I'm going to start with stage 3 unresectable non-small cell lung cancer. As we all know that in the 1995, the standard of care was to give sequential chemotherapy, radiotherapy for patients with locally advanced non-small cell lung cancer. As trials showed that sequential chemoradio gave a survival benefit with a hazard ratio of 0.87. Actually, we were practicing this until 2010, where it proved that concurrent chemoradiotherapy was more effective than sequential chemoradiotherapy, with a survival benefit and a hazard ratio of about 0.84. This practice was the usual practice till 2018, about 18 years, until we got the results of the Pacific trial. In the Pacific trial, patients with stage 3 unresectable non-small cell lung cancer received concurrent chemoradio, and then after that they were randomized to receive either durvalumab for 1 year versus placebo. And as we can see, that the addition of durvalumab post concurrent chemoradiotherapy on cases that were stable or regressed on the concurrent chemoradiotherapy gave a survival benefit. So patients who received durvalumab survived for 47.5 months compared to 29.1 months for those who did not receive durvalumab. Actually, this survival benefit was maintained till 5 years of follow-up with a hazard ratio of 0.72. This means that we have about 38% improvement in overall survival at 5 years, which is something considerable, of course. If we have a look at the subgroups, in the subgroup analysis of the survival, we'll find that if we look here at the PD-L1 status, we'll find that all patients did benefit from the addition of durvalumab, even the patients with a PD-L1 expression less than 1%. Actually, the most important side effect that we need to have a look at it and to know how to manage it is the pneumonitis post the addition of immune therapy in patients with lung cancer. As we can see in these CT scans, we'll find the CT scan to the left is showing the patient before receiving the immune therapy, and the one on the right is showing after receipt of immune therapy, and we can see here the pneumonitis that happened post the chemotherapy, which is one of the serious toxicities actually that we should be knowing how to deal with during giving immune therapy. Early diagnosis of this pneumonitis is very important, and early intervention also is very important. As we all know that usually the decision of management of pneumonitis depends upon the grade of the pneumonitis. So if we do have an affection of the lung between 25 to 50%, we should start with 1 milligram per kilogram prednisolone for the patient as early as possible, and of course to stop the immune therapy. And if we do have damage more than 50%, we shift to methylprednisolone at a dose of 2 to 4 milligrams per kilogram. So based on the Pacific trial, in patients with unresectable stage 3 non-small cell lung cancer without progression after previous concurrent chemoradio, durvalumab significantly improved overall survival versus placebo, 5 years stratified hazard ratio of 0.72. Maintain prolonged progression-free survival and time to disease metastasis, and lower incidence of new lesions with durvalumab versus placebo, consistent with the interim analysis. No new safety signal observed with extended follow-up. In February 2018, the FDA approved durvalumab for the treatment of unresectable stage 3 non-small cell lung cancer without disease progression following concurrent chemoradiation. So this is the first indication. The second indication I'm going to talk about now is the adjuvant setting. 2 and 3 in non-small cell lung cancer. After complete surgical resection, they received cisplatin-based regimen with whatever, pemetrexed, gem, docetaxel, or venetoclax for 1 to 4 cycles, and then after that, they were randomized to receive atezolizumab for 16 cycles versus best supportive care. And the primary endpoint was disease-free survival by the investigator. I'm putting the two trials together, not for comparison, but just to make it easier for you to perceive the difference. The other trial was the Keynote 091, where the same population of patients were randomized to pembro versus placebo, but this trial, chemotherapy is not mandatory. Some patients were receiving chemotherapy and some others did not, and the primary endpoint was disease-free survival. So let's have a look at the disease-free survival in the Empower 010. We'll find here that for the atezolizumab, the median disease-free survival was not reached. They were not able to calculate it. And for the breast supportive care, it was 37.2. And as we look here, we'll find that the hazard ratio was 0.81, but the p-value was 0.04. So significant boundaries was not crossed in the intention to treat population. So this trial didn't reach its primary endpoint in intention to treat, but we are going to discuss later that a subpopulation of the patients got a benefit, and based on this, the drug was approved by the FDA. What about Beryl trial? In the Beryl trial, pembro was given against placebo, and if you look here, we'll find that the disease-free survival for the patients who received pembro was 53.6 months versus 42 months for the placebo, with a hazard ratio of 0.76 and very significant p-value. Actually, this data was first released in the ESMO this year. So let us have a look at the overall survival. In the Empower trial, where atezo is used, there was no significant improvement in survival, but the problem is that still these data are immature, so intention to treat overall survival is not yet complete. But these are the provisional data that we have till now. And in the Beryl trial, we'll find that patients on pembro survived, median survival was 16.6 versus 18.9 in the placebo, so it wasn't statistically significant. This is what I was telling you about the Empower. For the patients receiving atezolizumab, progression-free survival was not significant for the intention to treat population. But if we look here at the patients who were PD-L1 positive, more than 50% in the tumor cells, they got a very good improvement in the disease-free survival with a hazard ratio of 0.43. This means that we have about 57% improvement in the progression. And also patients who had a PD-L1 expression more than 1% still have a hazard ratio of 0.66. And that's why on the approval of this medication, it was approved for patients with PD-L1 expression more than 1%. For the Beryl trial, the pembrolizumab, the benefit was present there as through the whole expression of PD-L1 according to the combined positive score. So more than 50 were benefiting, from 1 to 49 benefiting, and less than 1% also they got a benefit. These are the adverse effects in both trials, and they are all accepted, as you can see. So based on this trial, the Empower 010, nivolumab was approved. Atezolizumab was approved in the adjuvant setting of non-small cell lung cancer in patients who have a PD-L1 expression more than 1%. Those are some ongoing trials on phase 3 adjuvant chemotherapy, where patients with stage 1B to 3 resected non-small cell lung cancer received adjuvant chemotherapy according to the trial, the type of chemotherapy and the number of cycles, and then after that they were randomized to adjuvant immunotherapy versus the placebo. Actually, the design of these upcoming trials came from the design of the Empower trial, where the patient received chemotherapy before immune therapy. Actually, there is a number of trials studying the effect of durvalumab, nivolumab, and pembrolizumab in the same setting. However, these trials are still ongoing, and we don't have yet any results for them. So to conclude, Empower 010 met its primary endpoint, showing disease-free survival benefit with adjuvant atezo versus best supportive care after adjuvant chemotherapy in patients with resected stage 2 to 3A non-small cell lung cancer, with pronounced benefit in PD-L1 more than 1%. So on October 15th, 2021, the FDA approved atezo for adjuvant treatment following resection and platinum-based chemotherapy in patients with stage 2 to 3A whose tumors have PD-L1 expression more than 1%. Adjuvant pembro provided a statistically significant, clinically meaningful disease-free survival improvement following complete resection, and when indicated, adjuvant chemo if the patients are stage 1B to stage 3A, regardless of the PD-L1 expression. But these data are new, so still we don't have an approval for the pembro. So the last setting that I'm going to discuss with you today is the neoadjuvant setting. As we all know, the stage 3 non-small cell lung cancer is a heterogeneous group going from stage 3A to stage 3C. And as you can see in the lower table, that the survival is different so much between stage 3A reaching up to 42 months to 11 months in stage 3C. Actually, this group of patients, as being heterogeneous, usually we do have to go for an MDT decision for these patients. Sometimes patients are operated upon, and during the surgery, they were incidentally found to be N2. And in this group of patients, adjuvant chemotherapy plus or minus immune therapy is very important in this situation of the patients. But those patients who were diagnosed from the beginning with N2 disease, they should go for an MDT discussion and case-by-case discussion to put their multidisciplinary plan, whether surgery with multimodality or non-surgical with multimodality. Actually, this cartoon is showing us the efficacy of neoadjuvant chemotherapy. In the lower bar, we are going to see that the patients who are receiving immunotherapy pre-surgery, the immune therapy activates many different T cells to come into the tumor beds and to the tumor itself. So when the tumor is resected, usually we do have more and more diverse T cell population in the tumor beds. If we look in the upper row of photos, this is the situation when we give adjuvant immunotherapy. So the tumor is removed first, then we give immunotherapy. So T cells are activated, but we don't have this diversity of T cells that we do have in the case of the neoadjuvant setting. This is the concept trial that shows the same concept that I was discussing with you before, where the patients who received nivolumab pre-surgery, if we look at the graph in the middle, these dots represents 3 T cell clones. So we'll find how the T cell clone level started to rise once we get nivolumab, and then get to a high level, and after surgery they started to drop, but still we do have some clones. And if you look at the graph to the right, you will find that this is the level of the 3 T cell clones before resection, and in the resection bed they are still there. In the normal lung tissue they are still there, and in the involved lymph nodes and uninvolved lymph nodes the antibodies are still there. See, this proves the concept that immune therapy in the neoadjuvant setting improves the population of T cells in the tumor. So let us review the results of the CheckMate 816. The CheckMate is reviewing neoadjuvant nivolumab plus platinum chemotherapy for resectable stage 1B to 3A non-small cell lung cancer. Patients with newly diagnosed resectable stage 1B to 3A non-small cell lung cancer. Of course, we are excluding patients with EGFR mutation or ALK mutation with good performance status were randomized to receive nivolumab plus chemotherapy versus chemotherapy alone. We are giving this for 3 cycles. Then after 6 weeks, the patients were candidates for surgery at that time. And then post-surgery, we are giving optional adjuvant chemotherapy plus or minus radiotherapy according to the situation. The primary endpoints were the pathological complete response, event-free survival, and secondary key points were overall response, major pathological response, and time to death or distant metastasis. So let us have a look at the pathological complete response in all stages. So as you can see, the bars in blue are those of the nivolumab plus chemotherapy, and the bars in red are those for the chemotherapy. And it's obvious from the chart is that patients who received the immune therapy with chemotherapy pre-operative do have a higher rate of pathological CR reaching up to 24% versus 2.2% in the chemotherapy arm only. Of course, the p-value is 0.001, highly significant. Improvement evidence regardless of radiological downstaging. So what about the type of surgery that was done for the patient post the neoadjuvant concurrent chemo and immunotherapy? As we can see here, that the rate of lobectomy was much higher in the patients receiving immune therapy versus those who did not receive. The chart on the left is showing that the blue column is that for the patients receiving the neoadjuvant immune therapy, and you can see that in all stages, a larger population of patients were able to get a lobectomy than the patients who received chemotherapy alone. Also, the rate of complete resection was higher with the immune therapy, 83 versus 78, R0 resection, which is also a good sign that this immune therapy actually is a good option for the patients. This is the event-free survival. If you look here, we'll find that the patients who have received immune therapy with the chemo had an event-free survival of 31 months versus 20.8 months for the chemotherapy alone, with a hazard ratio of 0.63. And the p-value was very highly significant. So we do have an effect also on the time to disease progression. So if we look here at the PD-L1 status, we'll find that all groups of patients are benefiting. PD-L1 more than 1%, from 1 to 49, and more than 50%. They all are getting a benefit from the addition of nivolumab in the neoadjuvant setting to chemotherapy. So all cases with PD-L1 more than 1% are benefiting. This is the overall survival data. If we look here, we'll find that the median overall survival was not reached for the patient receiving the nivolumab plus chemo, and also for the chemotherapy, but the hazard ratio was 0.57. So this means that we have an improvement in survival of about 43% with a very significant p-value. In this chart, we are seeing patients with pathological CR. And as we can see here, that patients who got or received a pathological CR with the Nevo chemotherapy did much better than those who didn't reach a pathological CR, which is, of course, logic. For the chemotherapy, the analysis was not done because of the small number of patients who reached pathological CR. As you can see, there are only about 4 patients, so they couldn't do an analysis for the event-free survival for this group of patients. So to conclude, the median event-free survival was 31.6 months in the nivolumab plus chemotherapy arm versus 20.8 months in the chemotherapy only. The hazard ratio was 0.63. The pathological CR was 24% in the nivolumab plus chemotherapy and 2.2 in the chemotherapy alone. Based on this, in March 2022, nivolumab was approved by the FDA for adult patients with resectable tumor more than 4 centimeters or no positive non-small cell lung cancer in the neoadjuvant setting in combination with platinum doublet chemotherapy. These are a number of ongoing trials on the peri-adjuvant setting. I mean that the patients are receiving neoadjuvant immune therapy followed by surgery, and then after that, again, adjuvant immune therapy. There are a number of trials that are running now. Still, they are recruiting, so we still don't have data about whether giving the neoadjuvant pre and post-operative will be adding to our patients' disease-free survival and survival or not. So finally, we do have to decide between neoadjuvant and adjuvant chemotherapy. Each one of them is having pros and cons. In the neoadjuvant chemotherapy, we have better treatment compliance. We can add further therapy post-operatively. In vivo testing of the drug sensitivity can be done, of course. Better antigen priming, as we were discussing before, and potential downstaging, so this will facilitate surgery. In the adjuvant setting, we have more common, this is more commonly used in routine, we are used to it more than the neoadjuvant. No risk of surgical delay, of course, no increase of perioperative risk due to preoperative therapy, and complete pathological staging, of course, because we are not affected by the neoadjuvant chemotherapy. So multidisciplinary approach is very important to decide whether we are going to give the patient neoadjuvant or adjuvant based on each patient situation. So finally, to conclude, consolidation nivolumab after concurrent chemoradiotherapy based on 5 years data from the Pacific showed sustained overall survival plus durable progression-free survival benefit. An estimated 42.9% of patients randomized to nivolumab remained alive at 5 years, and approximately a third remained both alive and free of disease progression, which is actually a very good progress. Nivolumab was associated with meaningful safety profile and did not terminally affect patients' reported outcome compared with placebo. Based on this, it was approved by the FDA in 2018. In the post-concurrent chemoradiotherapy on patients who did not progress on concurrent chemoradiotherapy. Empower 010 met its primary endpoint, showing disease-free survival benefit with adjuvant atezo versus best supportive care after adjuvant chemotherapy in patients with resected stage 2 to 3A non-small cell lung cancer, with pronounced benefit in the PD-L1, of course, more than 1%. So that's why FDA approved atezolizumab for the adjuvant treatment following resection and platinum-based chemotherapy for PD-L1 more than 1%. Adjuvant pembro provided a statistically significant, clinically meaningful disease-free survival improvement following complete resection, and when indicated, adjuvant chemotherapy in patients with stage 1B to 3A, regardless of the PD-L1 expression. So, one slide is missing. Efficacy of adjuvant nivolumab was evaluated in the CheckMate 816, a randomized open-label trial in patients with resectable, histologically confirmed 1B, 2, and 3A. Median event-free survival was 31.6 in the nivolumab plus chemo versus 20.8 in the chemotherapy arm. The hazard ratio was 0.63, of course, statistically significant. Pathological CR rates 24% in the nivolumab plus chemo versus 2.2% in the chemo alone. And based on this, March 2022, the FDA approved nivolumab with platinum doublet chemotherapy for adult patients with resectable non-small cell lung cancer in the adjuvant setting. So by now, we are having an approved medication in each indication in the early setting. Thank you very much.
Thank you very much, Dr. Hanan, for this very well-organized lecture. Our next speaker is Professor Luca Bertolacini, a clinical oncologist from the Division of Thoracic Surgery in the European Institute of Oncology, Milan, Italy.
Thank you so much. It's a great privilege for me to be here, even in virtual mode. I hope that in the next Congress of OncoEgypt, I could be here in present with my friends and colleagues. Will speak about big data and machine learning, and my relation will be divided in a first analysis of big data. Is instrumental to the development of the outcome analysis in the clinical decision making, to optimize the pathway of care, to define the quality of care, to quantify the cost, and to compare the results. The information is heavily conditioned by the quality of the original data and some guidelines to create a surgical database that should be easy to complete with all necessary variables inside, with main primary and secondary outcome and main complication and morbidity and follow-up data. We also know manage the missing data in a large volume database. We checklist to elevate the science of surgical database research, like this published in JAMA Surgery in 2018. To be part of the European Society of Thoracic Surgeons database committee, the large database with than 100,000 lobectomy collected. So database, it's a big database. So what is a big data and what makes there is no single standard definition about big data. Big data is data whose scale, diversity, and complexity require a new architecture, technique, algorithm, and analytics to manage it, to extract value, and to extract an hidden knowledge. So the big database are the scale, the volume, the data volume, its exponential complexity, or the variety of the data, or the velocity. Data are generated fast and need to be processed fast. So the three VU characteristics, or VU characteristics: volume, velocity, variety, and veracity, with data in doubt. And what big data? Big data drive predictive analytics and data meaning and business intelligence. We are big data with bottleneck in technology that require new architecture, algorithm, technique, and needed, and in technical skills, the expert in using new technology and dealing with big data. If you cycle of the 4A of the data: acquisition, aggregation, analysis, and application, view of the big data, like the ESTS database with data storage, and these are analysis technique that we want to try to use, like time series, clustering, classification, predictive modeling, and visualization. Let's move to the second part of my talk about the machine learning comparison and machine learning consideration. Applied medicine are the supervised learning, the unsupervised learning, the reinforced learning, and the deep learning. Learning algorithm maps and inputs variable and features to an outcome with an outcome snow, where the feature and the outcomes can take on various across different applications. Some example: the first is the linear logistic regression, is a supervised learning algorithm research. Deep learning is a subclass of supervised learning, and we have here the artificial neural network, or a series of interconnected layers of neurons, the hidden layers which transform input data into scalar, and the output value of each neuron passes through nonlinear transformation, imitating the on-off nature of the biological neurons into the next layer of the unsupervised learning uncover hidden patterns in data without human intervention. So the only inputs to the algorithm are raw features and outcomes are unknown. And a typical example is the k-mean clustering. Learning, it's fundamental different to the framework compared to supervised learning. Without extensive train of data input output to pairs. And the classical example is the core technology at the heart of the surgical robotics, like we train an agent to perform an action like a suture wound, with incentivize the positive behaviors, the closing the wound, the disincentivize the negative behaviors, the bleeding as formalizing a reward function. Of machine learning studies applicable to thoracic surgery, and as you can know, the methods applied are to the artificial neural network, to logistic regression, to random forest, and so on. But implementation of machine learning and potential solution. We have a lack of model interpretability, a barrier to clinical investigation and implementation. We could have a low data quality and quantity, so the audit to the database is consistently for the accuracy. We could have a limited model evaluation post-deployment that implemented mechanism to monitor the model performance, and we sometimes have the ethical consideration, like the increased patient access to machine learning by expanding implementation to community and smaller hospital, it's appropriately inform the patient about the use of machine learning in clinical care. And now, example of the use of machine research. This is one supervised machine learning algorithm example. We perform a logistic regression analysis that define a risk stratification scheme for the synchronous oligometastatic non-small cell lung cancer. A paper joined with Antonello Pasini. Antonello is a great friend and is a physicist from the National Center of Research in Italy. It's a meteorologist and a climatology. And with Antonello, write an overview of the use of the artificial neural networks in lung cancer research. And we found that the artificial neural network in medical literature had not been performed in an accurate manner. Deep learning in this analysis of spontaneous pneumothorax in the city of Cuneo with environmental correlation with meteorological and air pollutants, and we found a correlation between meteorological and environmental variables and pneumothorax occurring warm, windy days with high atmospheric pressure and high mean nitrogen dioxide concentration. Use in this paper a supervised machine learning algorithm with this multivariable analysis and analysis to create a stratification risk class of bronchopleural fistula after pneumonectomy. For the big data is that the big data is an instrument of knowledge. The quality of data is rarely investigated since it's complex to measure, it's difficult to improve, as influenced by multiple contributors, and the analytic models for assessment of data quality it's really complex. Regarding learning and thoracic surgeon, we have an unrestrained optimism about future versus a confusion fear about a complicated math. So the machine learning is remarkable in future in surgery if implemented properly. So we need an interface with machine learning practitioner with a high level of understanding machine learning technique and awareness of current machine learning efforts in surgery and the recognition of potential shortcomings of machine learning, because we don't know what will be in the future, in a future with roads or no roads.
Hey, Doc, we better back up. We don't have enough road to get up to 88. Roads? Where we're going, we don't need roads.
So, your kind invitation. This is some picture from my place. It's named Busca in near Cuneo in the northwestern of Italy. Thank you so much another time for your kind invitation, and I hope to see in person in the next event. Thank you.
لا هي يعني في كلام كبير قوي على الارتفيشال انتليجنس ان كانسر عموما او في الميديكال فيلد. من ضمن الحاجات دي اللي هو اللي اتكلم عنها دكتور لوكا، ان هي يعني ممكن انت بتحط الداتا بتاعت العيان ممكن يفيدك واتس اوبتيمال فور ذس بيشنت. الاهم منه بقى اللي هي اللي ماشيه السكريننج اوف لان كانسر، لان ممكن مثلا تلاقي عيان، ودي ابليكابل وموجوده حاليا ومتطبقه في بعض دول اوروبا وكوريا. يعني في ابلكيشنز بتشتريها سوفت وير تتحط على يعني تجيب صور الافلام بتاعت البيشنت، لان احنا قابلنا الناس اللي بتعمل الكلام ده. تحط صور الافلام، لو العيان عنده 5-6 نوديولز في اللنج، لما بتدخله في السوفت وير يقول لك النوديول نمبر 1 البروبابيلتي اوف كانسر مثلا 1%، النوديول نمبر 2 از بناين، النوديول نمبر 3، فبيديك جايد العيان ده محتاج تعمل له حاجه ولا لا. فده طبعا ده ابلكيشن بتغذي بيها المكان، بس طبعا دي يعني برضو ليها كوست، مش فور فري. يعني الحاجات دي كلها ليها كوست، وهم كمان بيتكلموا دلوقتي عشان يكسبوا اكتر، ان هو مش بيبيع لك السوفت وير ده، هو عايز يديلك بير بيشنت تدفع كذا، يعني مش يديك السوفت وير على بعضها. هو طبعا الموضوع كبير، وده في الفيوتشر هيبقى ليه يعني امباكت كبير قوي في الميديكال فيلد عموما.
طيب we have to introduce Professor محمد عبد الرحمن, Professor of Clinical Oncology, Qasr Ain University, Qasr Ain Department. He will talk to us about small cell lung cancer updates in immunology, in immunotherapy.
محمد عبد الرحمن, هي دي مظبوط, Professor of Clinical Oncology قصر العيني, Consultant at Aswan Cancer Center, Specialized Medical Center. Our talk today about immunotherapy in lung cancer, small cell lung cancer. Small cell lung cancer represents about 13% of all cases of lung cancer. It is highly linked to smoking. Most of patients presents while they are current smokers. Extremely rare to have patients not smoker or ex-smoker at presentation of small cell lung cancer. And most of patients presents with extensive disease. About 2/3 of cases are extensive at presentation. Most of patients presents at old age, more than 65 years old. Small cell lung cancer is highly chemosensitive, but unfortunately most of patients will relapse, and upon relapse the prognosis is very dismal, with a progression-free survival in the range of 6 months and a 5-year survival in the range of 6% only. So we have to go for to search for another effective systemic treatment rather than chemotherapy. It is highly immunogenic tumor. It is the 5th immunogenic tumor as indicated by tumor mutational burden. The history started in 1970s, and a lot of agents have been tried. Till 1990s, we reached the platinum-based doublet, small cell like non-small cell. cisplatin and vipsid or carboplatin and vipsid in both small and non-small cell lung cancer. From 1990s till now, the evolution occurred in non-small cell lung cancer, not in small cell lung cancer. Moving from platinum vipsid in non-small cell lung cancer before the year 2000 till other doublets like platinum with gemcitabine, paclitaxel, docetaxel, and others. And then the non-small cell lung cancer moved to the era of genetics, targetable mutations, immunotherapy, and still till the year 2018, small cell lung cancer is being treated with platinum vipsid doublets only. From the year 2018, we started the approval of immunotherapy in small cell lung cancer. This is the landscape of trials of immunotherapy in small cell lung cancer. We'll talk about first-line therapy. We'll talk about maintenance after induction chemotherapy with immunotherapy, and finally, second-line and first-line therapy. For the first-line therapy, you have two pivotal trials, phase 3 trials, which are the Empower and the Caspian. This is our main talk today. For the maintenance, for the maintenance after induction chemotherapy, we have only two negative trials. We don't have evidence for immunotherapy as maintenance after induction chemotherapy. And for the second line therapy, we'll concentrate on the Checkmate 3C1 and the pooled analysis of keynote studies for pembrolizumab as monotherapy. For the Empower trial, which is a phase 3 trial, randomized patients to chemotherapy, patients with small cell lung cancer with good performance status. PD-L1 is not mandatory for inclusion of the patients, although stratification was based later on PD-L1 and performance status. Patients were randomized to either atezolizumab added to carboplatin vipsid or carboplatin vipsid alone. Then patients were maintained on atezolizumab or placebo on the standard arm. Patients were followed up for survival analysis, which is the primary endpoint. Prophylactic cranial irradiation was permitted in the study, while consolidation thoracic irradiation was not permitted. This is the primary endpoint of overall survival. There was a significant improvement in the range of 2 months regarding the median overall survival, and about 13% absolute improvement at 1.5 year overall survival. As most of the immunotherapy data will have typical curve in the first 6 months, then after from the 6 to 12 months, we have separation of the curve. So you will have a median progression-free survival of similar or near results 5.2 versus 3.3, less than 1 month's difference between both arms, but this has affected overall survival, and at long term, 1.5 years, 2 years, and so on, you will have a good separation of the curves. Regarding the overall response rate, it was similar between chemo versus chemo-immuno, but for immunotherapy, the response was more durable. This is because of the continuation of separation of the curves after 6 months. Most of subgroups gained the benefit from addition of atezolizumab, apart from patients with brain metastasis, but they have borderline improvement, but the number of patients is not conclusive, only 35 patients. For the role of PD-L1, no predictive value for the PD-L1 in the subgroup analysis. So it is effective, atezolizumab is effective either PD-L1 high or low. Of course, this improvement was not for free. It was on expense of toxicity. Although we have more or less similar toxicity, but immune-related toxicity has doubled with the addition of atezolizumab in spite of less toxic deaths. This is the second trial in the induction, which is the Caspian trial, with a similar design to the Empower, but we evaluated the addition of durvalumab to chemotherapy or durvalumab tremelimumab to chemotherapy versus the standard arm of chemotherapy alone. Then patients on both arms of durvalumab were maintained on durvalumab. Then patients would follow till disease progression. In this trial, Caspian, the prophylactic irradiation was optional, not mandatory like in the Empower trial, and the primary endpoint was the overall survival. First, tremelimumab did not Tremelimumab did not improve survival compared to chemotherapy alone. So if you add durvalumab to chemotherapy, you will improve survival. If you add tremi to both durvalumab and the chemo, survival is the same like chemo alone. So tremi failed. For durvalumab, and after a follow-up of more than 3 years, we have an improvement by about 30% in the survival, and we have long-term survival of 17.6 at 3 years. This is a very good results in extensive and metastatic small cell lung cancer regarding a very long 3-year survival. This is overall survival curve. And as you see, the curve starts to separate after 6 months. This is a nearly consistent curve seen in most of the immunotherapy trials. As you see, the difference in the progression-free survival is nearly none. 5.1 versus 5.4, only 0.3 months. This is few days. No difference in the median progression-free survival as the curve starts to separate after 6 months till 12 months, and then separation continued till 3 years. This is the most important benefit of immunotherapy. Patients who responded well will continue to respond for a long duration. This is the subgroup analysis. Most of the patients gained nearly the same benefit with a hazard ratio in the range of 0.7 to 0.8 in most of the subgroup analysis. Again, this is not for free. It was an expense of toxicity, and we have, like the Empower trial, nearly comparable toxicity in general, but we have doubling of the immune-related adverse events, 4 times of immune-related adverse events, and even up to 10 times increase in the high-grade immune-related adverse events like pneumonitis, hepatitis, and thyroid affection. Back to our landscape, we have finished the first-line therapy. Other trials were negative. Coming to the maintenance with immunotherapy after induction chemotherapy, as we mentioned in the beginning of the lecture, it was negative and even with added toxicity. This is a comparison between the Caspian and Empower. The Keynote is a negative study, although the p-value in the Keynote study was less than 0.05 because the statistical design of the Keynote 604 evaluating pembrolizumab added to chemotherapy was put at a very critical level of 0.0125. And although it reached a 0.0164, it did not reach statistical significance. So Pembro failed in the induction chemotherapy of small cell lung cancer. These are the trials for the maintenance, and as we mentioned, it was negative studies, either evaluated Pembro or Nivo added to ipilimumab. Actually, ipilimumab failed 3 times. Failed in the induction, failed in the maintenance added to nivolumab, and it will fail in the second line and subsequent lines added to nivolumab in its phase 2 CheckMate 032 study. So forget about ipilimumab in the small cell lung cancer. Forget about maintenance after induction chemotherapy. Use atezo or durvalumab with good evidence in the first line. And coming to second line and subsequent lines, we have 2, I will not say positive studies, but I will say effective studies. The CheckMate 331 evaluate nivolumab monotherapy versus chemotherapy, and 2 or the bold analysis of the Keynote 158 and 028 evaluated Pembro as monotherapy versus chemotherapy. Starting with the CheckMate 331, it was an open label randomized phase 3 study which randomized patients to nivolumab single agent versus chemotherapy, mostly with topotecan, and with overall survival as the primary endpoint, and follow up more than 1 year. The CheckMate originally is a negative study. There is no improvement in the overall survival. But I said it is an effective study because guidelines changed upon it. How? It is negative study, no improvement overall survival, but subgroup of patients with absence of liver metastasis and subgroup of patients with low LDH gained a survival benefit for nivolumab versus chemotherapy. The second or the most important finding of this study is the highly reduced toxicity. Toxicity of chemotherapy more than 70%, while for immunotherapy less than 14%. And upon this study, nivolumab was approved as a second-line therapy or as other preferred regimens in the management of second line of small cell lung cancer based on the toxicity profile and the subgroups of no liver metastasis and low LDH. Coming to the second evidence in the subsequent therapy, we have the pooled analysis of two keynote studies comparing pembrolizumab versus chemotherapy. Actually, selection is very difficult, very good performance status with third line or more. This is very difficult to find such like patients. Two doses used in the both studies. And the primary endpoint was the response rate, overall response rate. It was similar, overall response rate between both chemotherapy and pembro, but for pembro, the response was more maintained, was more durable. And upon this study, pembro has gained approval in the subsequent therapy as other regimen in the NCCN. Now coming to our conclusion, what is the location of immunotherapy in small cell lung cancer now at the year 2022? We have started to approval at 2018, so we have only 4 years of data. After these 4 years, extensive stage and metastatic small cell lung cancer, the preferred regimen according to the NCCN is chemotherapy with platinum doublet added to VB16 and the addition of both, or either atezolizumab based on the Empower study or durvalumab based on the Caspian study will improve survival by about 2 months, and it will be a durable response. If you have a CNS disease, it should be treated with radiation therapy, but the sequence to start with radiation or a chemoimmuno or the reverse chemoimmuno followed by radiation therapy depends on the patient symptoms. For the maintenance, no rule for maintenance of immunotherapy following first line induction chemo. Maintenance will be after induction chemoimmuno. If you started with atezo plus chemo, you can continue or you should continue with atezo. But if you started with chemotherapy alone, no data to continue with immuno if not is used in induction. For the second and subsequent lines, immunotherapy is categorized as other regimen, not the preferred regimen. The preferred regimen in the NCCN is to retreat or rechannel with platinum-based Vepsid if you have a response rate more or progression-free survival more than 6 months. If less than 6 months, you have chemotherapy or nivolumab or pembrolizumab. Nivolumab was approved upon according to the Checkmate 331, although negative study, but especially if you have a patients with absence of liver metastasis, patients with low LDH, this is the best patients to be treated with nivolumab according to the Checkmate. In addition to the lower toxicity profile if you treat your patients with second line chemotherapy, pembrolizumab was approved upon according to the pooled analysis of the keynote studies according to its response, not its response as a figure, but its duration of response, the highly prolonged duration of response. This is why pembro was approved in the subsequent therapy. This is the NCCN guidelines, and thank you.
Thank you very much, Professor Muhammad Abdurrahman. Our next speaker is Professor Abdurrahman Muhammad, Professor of Surgical Oncology of NCI. He will talk about toward optimal surgical therapy for early stage non-small cell lung cancer.
Bismillah ar-Rahman ar-Rahim. Thank you very much for this introduction. I would like to thank the organizing committee for giving me the opportunity to give this lecture about surgery for early stage non-small cell lung cancer. To optimize our surgical therapy, we have to answer some questions so that we have the proper decision to be given to our patient. First of all, we have to define what is early stage disease and the survival for those patients. Is there any need to do mediastinal staging for patients with early stage non-small cell lung cancer? Why to do surgery, not other local control therapies? Do we have to do it open surgery or minimal invasive surgery? What are the new approaches in surgery for early stage lung cancer? And what is the extent of resection? Do I have to do lobectomy, or there is what we call sublobar resection, which is resection less than a total lobe? And finally, the extent of mediastinal lymph node staging or mediastinal lymph node dissection. Early stage disease included stage 1 and selected node negative stage 2A disease. And as you see, this is the spectrum of patient who defined as early stage disease, including all stage 1 and stage 2A disease. And when you look to the survival ranges from 92% to 60% for patients with stage 2A disease who are node negative. So the first question, do we have to do mediastinal staging? This is a big study for patients who are PET negative mediastinum, included 284 patients. Occult lymph node metastasis was found in 7% of those patients with T1 or T2 tumors, but node negative by PET. However, T2 tumors were more likely to have occult N2 disease than T1 tumors, which is 11.8% versus 3.6% for T1 tumors. Pure solid tumors have a higher probability of having N2 metastatic disease than patients with tumor with ground glass opacities, which is ranging from 12.6% for solid tumors compared to only 3% for patients with ground glass opacity. We have to know that centrally located tumors harbor more metastatic lymph node than peripherally located tumor, which is 17.5% versus 4.4% for patients with peripherally located tumors. Also, we have incidence of 33.3% for patients with solid T2 tumors to have an occult N2 disease, whereas only 2% of patients with peripheral tumors with ground glass opacity having N2 disease. So it's very important to classify and to know whether this tumor is solid or having ground glass opacity, and the percentage of ground glass opacity, and which tumor, whether central or peripherally located. Another risk factor is old age, high carcinoembryonic antigen level, and we have to do CEA level because this carries a higher incidence of mediastinal nodal metastasis, and there is also, it's considered a best prognostic factor, and the consolidation tumor ratio reaching 90% on high resolution CT. When all these four predictors are available in one patient, there is a probability of nearly 34% to having a tumor in the lymph nodes in patients with stage 1 disease. Patients harboring EGFR exon 19 deletion have a higher, significantly high probability of having occult mediastinal lymph node disease. Nodal metastasis was not observed in patients with solid tumors less than 1 centimeter or non-solid tumors less than 3 centimeters. So if we have tiny T1 tumor, you don't have to do mediastinal staging for those patients because the probability of having mediastinal disease is less than 1%. So whom do we stage? We have to stage patients with centrally located tumor even if the mediastinum is radiologically negative. Tumors more than 3 centimeters, and sometimes, or some reports recording that we have to do it for tumors more than 2 centimeters, even if these tumors are peripheral. N1 lymph node positivity in patients with PET-CT, lymph nodes more than 1 centimeter, even if the PET is negative. Positive lymph nodes in PET scan, even if these nodes are less than 1 centimeter. And lastly, low SUV uptake for the tumor, even if the mediastinum is negative. So why we are choosing surgical resection? Benefits of surgery include complete eradication of the tumor in the draining lymph nodes, single visit procedure where the patient just go to the hospital doing surgery and to be discharged after maximally 1 week. Accurate pathologic staging because you have properly staged the T and N stage of the patient. Wide safety margin, you are removing the tumor with a wide safety margin. Proper planning for post-operative therapy because the pathology report carries many prognostic factors that leads you to choose whether to give adjuvant treatment or not for those patients. provide material for tumor subtyping and genetic studies, and proper evaluation of patient prognosis for the same reason. It seems that the T category play an important role in decision making, in diagnosis, staging, and extent of treatment in patients with early stage non-small cell lung cancer. What are the advances in surgery nowadays? Surgery makes therapy less traumatic because we are in due decades now in the era of minimally invasive surgery. Pain also is minimized. And when the surgeon have more experience with this single port technique, more complicated techniques can be performed using single port thoracoscopy, and it's widely accepted nowadays all over the world. When we are comparing thoracoscopic versus open surgery, which is still indicated till now in some patients, we have to compare oncologic safety, morbidity and mortality, survival in both techniques, overall cost of both techniques, because one technique may be expensive more than the other, hospital stay, and functional outcome. This is one of the very well organized studies, included more than 500 participants. Half of these patients underwent open surgery and have underwent video-assisted thoracic surgery. Major adverse event developed in 30% of patients with VATS technique compared to nearly 38% of patients with open surgery. At 1 year, there was no difference in cancer progression-free survival or overall survival for both techniques. And as you see, this is in the first chart on the right side, indicates the first 5 weeks during admission of the patient and after discharge, the quality of life of the patient, the quality of life, the red one for the minimally invasive and the blue one for open surgery. But as you see, by the end of this chart, starting from 6 months to 1 year, there is no difference in pain quality of life for both techniques. So the same on the left side, the quality of life of the patient and the need for the pain control is much less for patient with minimally invasive compared with patient with open surgery. This is another study showed that there is no survival difference between VATS versus open surgery. However, older age, larger tumor size, and higher incidence of lymph node metastases are associated with worse survival. VATS technique is associated with fewer complications, and patients with VATS surgery are usually demonstrated 2 days shorter length of hospital stay compared with open surgery, and this leads to minimization of the total cost of the procedure with lower cost for patient with minimally invasive compared for patient with open surgical resection. Nowadays we are in the era of robotic surgery. Robotic surgery is usually applied also for patients with lung cancer, but it's not widely accepted all over the world. It's usually accepted mainly for pelvic surgery. And this is a meta-analysis comparing robotic, which we call it RATS, robotic assisted thoracic surgery, versus VATS, which is video assisted thoracic surgery. This is meta-analysis included 18 studies. More than 11,000 patients included, 5,000 of them underwent robotic surgery and 6,000 underwent thoracoscopic surgery. Robotic surgery associated with lower conversion rate. By mean, we are lower conversion rate from minimally invasive to open, associated with less blood loss, shorter duration of hospital stay, and shorter post-operative tube drainage also. But actually it's associated with higher cost than video-assisted thoracic surgery. There was no significant difference between RATS and VATS during the operative time, morbidity and mortality, and disease-free survival. Sensitivity analysis showed that there is no significant difference were found between the two techniques regarding the conversion rate, number of retrieved lymph nodes, and the number of stations of the lymph node dissected, and the overall is more difficult than patient with, to do lobectomy, because in segmentectomy you have to go to the fissure and you have to find the segmental artery, which is the lower left one, and then you have to find the segmental bronchus, which directly present behind the artery, and sometimes the first picture sometimes you can find the segmental vein, as you see in the picture in the upper middle one. Comparing lobectomy to segmentectomy, this study included patients with tumors smaller than 2 centimeters in diameter compared to tumors between 2 and 3 centimeters in diameter. They found that in patients with tumors smaller than 2 centimeters in diameter, there was no survival benefit between sublobar resection or lobectomy. For larger tumors who are more than 2 centimeters in diameter, the median survival was significantly better in lobar resection group, which is 70 months versus 44 months, which is statistically significant. This is the meta-analysis comparing the sublobar resection versus lobectomy, and the recurrence-free survival for patients with segmentectomy is 1.4 times greater than those in patients with lobectomy. However, the overall survival, the combined hazard ratio of the 6 studies is 1.5, demonstrating that there was no difference in overall survival between segmentectomy and lobectomy. There was no also difference in perioperative morbidity and mortality in both techniques, especially when we are dealing with a patient who are fit for surgery and patient with no other comorbidities. What kind of sublobar resection do I have to do? As we said before, segmentectomy, anatomical segmentectomy, or wedge resection. The answer in this slide, as you see, there is a number of dissected lymph nodes is much higher in segmentectomy group compared with wedge resection group. Segmentectomy associated with significantly better cancer-related 5-year survival than wedge resection for stage 1A tumor, which is 71% versus 48%. Wedge resection associated with higher incidence of local recurrence, reaching up to 55% compared to 16% for patient with segmentectomy group. Sublobar resection is indicated in some group of patients with poor pulmonary function that cannot tolerate lobectomy. Should be considered for patient with metachronous or synchronous primary lung tumors, and there was no difference in survival compared with lobectomy. In some patients with evidence of less aggressive tumors, namely minimally invasive adenocarcinoma or adenocarcinoma in situ, evidence suggesting that tumors with low uptake in the PET-CT, we can do segmentectomy or wedge resection in this group of patients. Now we are in the era of what we call selective lobar lymph node metastasis. By this picture, as you see, the upper lobes usually drains up and the lower lobes usually drains below. The upper lobes usually drain in the paratracheal, upper and lower paratracheal lymph nodes, and the lower lobes drain in the subcarinal and inferior pulmonary ligament lymph node. However, the middle lobe of the right lung usually drains in both up and down. So it's very conflicting when you are dealing with tumor in the right middle lobe. So what to do? We have a meta-analysis to answer this question. Do we have to do complete mediastinal lymphadenectomy or to do selective mediastinal lymphadenectomy? This meta-analysis included 5 retrospective studies and 1 randomized controlled trials. This included more than 5,000 patients. 1,400 of them underwent selective mediastinal lymphadenectomy, and they found there is no statistically significant difference in survival at 1 year and 5 years regarding overall survival and disease-free survival. There was no statistical difference in between the two groups regarding the local recurrence and distant metastasis. Among the postoperative complications, pneumonia, atelectasis, and prolonged air leak are more common in patients with complete mediastinal nodal dissection. The last question regarding the delay in surgery for patients with early stage non-small cell lung cancer. Do I have a prolonged time, especially in the era of COVID-19? Should I have to delay the treatment to be given to the patient or not. We have what we call TTS, which is the time to surgical treatment, which is defined the time between the preoperative diagnosis by CT scan and the start of surgical treatment. Longer time and increasing the risk after 12 weeks delay. If there is delay more than 12 weeks, we have a risk of 0.4% incidence of local recurrence. However, factors associated with delay in surgical therapy include African American race, higher areas of deprivation, lower hospital caseload. If this hospital is not practicing thoracic surgery on a routine basis, there is usually delay in providing this service, and the use of endobronchial ultrasound or mediastinoscopy sometimes lead to delay because you have to wait for pathology. Surgical treatment within 12 weeks associated with significantly better overall survival than those procedures delayed for more than 12 weeks. Lastly, take a home message. The present day standard of care for early stage lung cancer is to do lobectomy and hilar and mediastinal, selective hilar and mediastinal lymph node sampling or dissection. Minimally invasive surgery is advisable if applicable, and if you have the instruments and the staplers associated with it, it's better tolerated by the patient and have the same oncologic outcome as open surgery. Several randomized trials are underwent to decide whether to do sublobar resection, especially wedge resection, because segmentectomy for T1 tumors are now considered by some as a standard of care. Limited resection is routinely used for the resection of lung cancer in patients with limited pulmonary reserve and other high-risk comorbidities. Thank you very much.
Thank you, Professor Abdurrahman.
Have you operated on patients who have received neoadjuvant immune therapy?
Have I operated in patients received neoadjuvant?
Neoadjuvant.
Yes.
Immune therapy. Immune therapy.
Immunotherapy? Only maybe 2 or 3 patients.
Have you noticed any difference in resection, in fibrosis? Because some literature...
Yes, the responding patients having very tough dissection. Yeah.
Yeah, so it's really affecting the dissection.
Yeah. Like a little bit like radiation therapy, local radiation.
Yeah, okay. Thank you, Dr. Abdurrahman. By this session, this presentation, we are going to end this session and we're going to move to the metastatic lung session.